And on the screen, if you want to point to stuff, you can just use this, and then you just go slide by slide. Okay?
All right. Try to talk louder.
You don't mind if I just set this right here, do you?
No.
All right.
All right.
Is that too dark? No.
That's fine for me.
Okay, nobody fall asleep.
All right, so I'm going to start with the MRI spine pathology lecture. I don't know if you guys have had a chance to see it yet or not, but I'll just be going over each slide as we go. So the first thing we're showing here is called syringomyelia, or some people call it syringohydromyelia. That's just a semantic difference between, what is the origin of the abnormality. And what you see here on the images is a T2 weighted image. You see some, T2 hyperintense fluid signal intensity in the cord, and that's, of course, going to be low in signal intensity on the T1 weighted images. So it's really just a fluid-filled area, and it's usually right in the very center of the cord, kind of tapers off at either end. Most of these can be caused by Chiari malformation. I'm not sure if you're familiar with that, but that's when there's some malformation in the brain, and the cerebellar tonsors can herniate into the foramen magnum and cause some pressure at the cervicothoracic junction and cause some obstruction to the usual flow of CSF, and it can accumulate in the spinal cord. So it can also happen with these other conditions: myelomeningus, CLL, basilar skull impression, or platybasia, protrusion of the foramen magendi or Dandy-Walker cysts. Depending on how large it is and how wide it becomes, that the patient may or may not have symptoms with it. They can definitely have sensory loss and muscular difficulty, weakness, that kind of thing. They may have even some muscle spasms, that kind of thing. So usually if a patient has known Chiari malformation, that being the most common etiology, they may want to do some cervical spine imaging, thoracic spine imaging, to see if they find the syringomyelia in the cord. And so I guess the one thing that you want to look out for if you see this on a study is, let's say the patient has been ordered just for a cervical study. You see a little bit of it beginning again in the thoracic cord, because sometimes it can be over a segment and then it stops, or it looks like it stopped and then it opens up again further down. If you see something at the edge, it might be useful to check with the radiologist, see if they want to extend the imaging any lower, make sure they're getting the full extent, or see if they need to have the patient come back for another study or anything like that. This doesn't usually need any contrast administration, so just a non-contrast study is fine. So here's an abnormality called a tethered cord. It's a little bit difficult to see on this image, and that's because it's actually a little bit of a difficult thing to diagnose. But the main thing that you're looking for is that the spinal cord comes down lower than expected. And one of the things that we always report, or that many radiologists report on their lumbar spine MRIs, you'll see they'll mention where the end of the cone is. That's the tip of the cord ends. And then from that, you have the terminal nerve roots just coming off below there. And any time you say that it's, below the L2 level, you start to get suspicious of this tethered cord. So what happens is, as the spine and the cord is developing, the cord actually ascends in the spinal canal during development, and if it's prevented from ascending, then it stays down. It's not like it grows down. It's just that it gets prevented from being pulled up. And usually you may get a hint that this has occurred in a newborn baby, because it's associated with spinal dysraphism or spina bifida occulta. Usually if a patient has overt spina bifida, it's really obvious and is usually diagnosed prenatally, but sometimes you have where the posterior elements of the spine don't completely fuse in the back, and that's associated with this abnormality. And it won't be that obvious on external examination, except that the patient may have a little sacral dimple right at the top there. And so we'll often do an ultrasound to evaluate a neonate with a sacral dimple like that. And ultrasound is pretty good for, finding the level of the cord, making sure that it's not tethered or stuck posteriorly. You see how this is also stuck posteriorly in the canal instead of just kind of, floating down in the center of the canal. So that'll show stuck posteriorly, not moving normally, and it may show thickening of the filum terminale that is preventing the cord from ascending. Occasionally, we won't see a sacral dimple, or it'll get missed in the early neonatal period of imaging, and these can develop in patients as they get older, that they may end up developing some neurologic weaknesses and difficulty in walking. They can develop scoliosis as a result because their spine isn't allowed to grow normally. The cord is really holding it together. So you may end up being, evaluating this late in the process, or sometimes you may be evaluating this in a patient who was screened by ultrasound first and found an abnormality. So, this is there's nothing, additional that you need for this. You don't need any contrast or anything like that. I guess the most important thing is, if you're dealing with imaging a child or a baby, is just to make sure that that you have nice still images so that you can see these kind of subtle findings. The radiologist is going to be looking for, for thickening of the filum terminale down there. Thickening is considered greater than 2 millimeters in diameter, so we're talking about measuring, very small structure. And also, sometimes it's difficult to determine whether you have a little bit of lipoma associated with the tethered cord, which is frequently associated with it as well. The other last thing you might want to consider is continuing the axial imaging down through the level of the defect, if there is a defect in the posterior elements of the spine. And probably, as long as they're planning on seeing this, planning on evaluating it for a patient that was screened with ultrasound, you may already be aware to go that low. But if you're just seeing this and it was an undiagnosed thing, if you see a very low cord below the L2 level, you might want to think about going lower or checking with the radiologist to see if they want to image any lower and see if there is any defect in the spine itself. This is just another image of a tethered cord, and this one is associated with a fibro-fatty filum. It's like a partially fatty structure, partially fibrous, partially fatty structure there at the end of the conus there. So that usually wouldn't see something quite this dramatic there, but just something something to look for. So here's the herniated disc that I'm sure you've all seen in your clinical rotations. So, the discs are cushioning our vertebral bodies. Once a vertebral body maybe gets a little bit older, it's at risk for herniating. What happens is, the central portion of the disc, the nucleus pulposus portion of the disc, can become, ruptured or, protrude through the annulus portion of the disc, the denser fibrous portion of the disc, or the whole thing can just kind of relax with time. So, it depends on whether it's a diffuse process or whether it just kind of, pokes out through a hole, whether you call it herniation versus protrusion versus extrusion, and that's a terminology you need to worry about. But a couple of things you would be expecting these patients to have would be, some pain in the buttocks, the legs, the feet. One thing that's helpful to the radiologist and to the doctor who ordered it is to get a good clinical history. If the patient says they have pain going down their leg or legs, which leg is it, how far does it go down, because that tells us, what level of the cord is being affected, of the spine is being affected, because many people will have herniated discs and have no symptoms, but some people will have several discs, and it's hard to tell exactly where the symptoms are coming from. So it just gives us an idea, where to look for the specific pathology that's causing the patient's specific complaint. Now, the way these are treated, usually they try just resting, and then eventually some exercise. Walking is really helpful for it. Anti-inflammatory medications, sometimes injections can help with the symptoms that go down your leg, epidural steroid injections, and sometimes the patients need to undergo surgery to remove that part of the disc that's sticking out, or at least decompress the spine so that the herniated disc is not pushing on the nerve roots quite so much. This is a condition called spondylolisthesis. This is when the vertebral bodies don't line up normally, so this is another thing that a lot of radiologists start out mentioning. just that the alignment of the spine, all the vertebral bodies posteriorly should line up in perfect alignment with each other. When a vertebral body is a little bit scooted back on one, that's called, that way we describe as, for example, retrolithesis of L4 on L5, retro meaning, posterior, and then if it's scooted anteriorly, then you'd say anterolithesis of L5 on S1. So there are a few ways that this can occur. Many times, one of this severity would usually be due to a defect in the pars interarticularis, or just a pars defect as we call it. And those ones will usually be at the L5, S1. Pars defects are really common at L5, but you're also going to see this kind of less dramatic slippage with just facet disease, where the facet joints come in contact in the back. They can get really hypertrophied, and it can push the spine out of alignment in the front to back projection. And once that happens, then any kind of disc disease that is protruding into the canal, or any hypertrophy of the ligamentum flavum in the back, that's just going to contribute to overall narrowing of the central canal. So that can cause some, really significant spinal stenosis, and it almost always causes compression of the nerve roots that are coming out. These patients are going to have low back pain. They can have radicular symptoms down either leg. If they have enough stenosis, like this patient in this case, they can have something that's called neurogenic claudication, where they walk for a while and their legs get really numb, and then they rest and they feel better, and so on and so forth. These patients, something this severe would generally need surgery to, line things back up, or at least stabilize them from slipping any further and causing damage to the nerve roots. Here's another example of spondylolisthesis. This one looks a little bit more like degenerative in etiology. Pretty significant, though. It's causing buckling of the cord. You're probably not going to see it at this level on a usual basis, but it can become quite severe. And in the case of a cervical spine, you might have more symptoms in the upper extremities than in the lower extremities, but they can still have lower extremity weakness as well. So a spinal hemangioma, it sounds like a tumor, but it's a benign tumor. It's a benign lesion. We see them really, really frequently, especially the amount of imaging that we do. You can see them both on CT and MRI. They can look really scary at first. They can look like something serious. It's very bright on T1 weighted image and low in signal on bright on T2 weighted image and low in signal on the T1 weighted imaging. The key to this lesion is that with a fat suppressed image or a stir image, you're going to see that the bright signal will drop out. Fat suppressed T2 or stir image, you'll see that this fat signal will suppress out, and that gives you an idea that it's a hemangioma. Some radiologists don't mention them unless they're very large, or unless they suspect that it could be causing symptoms. Very rarely, if it takes up the whole vertebral body, there's a possibility, that the vertebral body could collapse from it. And I have seen that occasionally surgeons will reinforce them with bone cement like they do for a patient with a compression fracture. But given the number of hemangiomas that happening is fairly rare. I don't think that they have any correlation with pain or anything like that. It's just kind of, something to be aware of, but not to be alarmed about. So here's a spinal ependymoma, and this is a benign tumor as well, but of course anything in the spinal canal is not totally benign because it can take up room and cause compression of the cord or of the nerve roots. They develop from the ependymal cells lining the canal or from ependymal breasts. It's a little bit more common in males. So the patients may have any kind of neurologic symptoms or pain symptoms, weakness, sphincter dysfunction. The importance of recognizing this lesion is that this one is a post-contrast image, and it shows up really beautifully on the study, but if they weren't expecting it, if they were thinking that the patient may have weakness and pain from just a simple herniated disc or something like that, then they wouldn't have a full evaluation of the ependymoma. And so it'd be important if you saw something that's rounded like this, that's in this, in the canal like that, is to make sure that we're doing some post-contrast imaging as long as a patient's allowed to have contrast. And if not, just check with the radiologist and make sure that they won't want to do contrast. Same thing goes for any other kind of, spinal tumors, like metastases would be a common one. Anytime you see, these rounded lesions, that kind of thing, you want to give contrast to try to, get a full evaluation. And they may not always be expecting that we need contrast. So just check with the radiologist if that comes up. Here's another image of spinal stenosis. I talked a little bit about stenosis due to the spondylolisthesis earlier. Stenosis just means generally narrowing of the spinal canal and the lateral recesses. So the spinal canal, would be this triangle here, and the lateral recesses are sort of these, this part of the triangle over to the side. And generally some people use a measurement overall of like how narrow or how wide the canal is. So some people use the measurement, some people just look overall, but any degree of narrowing could be considered, stenosis. This one's a really severe one. It can be contributed by several things. So one thing is overall, you can see that this disc, especially if you compared it to the vertebral body above, the disc is, diffusely bulging. So it just has kind of gone from this to that. And whenever you see that it has this flattened and slightly bulging posterior contour like that, you know that that's a diffuse disc bulge. These are the facet joints that I was talking about before. They can get a little bit hypertrophy. These ones are a little bit big here, and that causes narrowing centrally. And then this here is the ligamentum flavum that gets really thickened, and all of these three things contribute to it. And you can imagine if the patient had any spondylolisthesis at that level, that it would be extremely narrow. Already this one is at least moderately narrowed, so this patient would be having some pretty significant symptoms. Once again, the symptoms are similar to a lot of things that occur in the spine: pain, numbness, weakness, that kind of thing. They can sometimes, manage these patients with injections and things like that, pain control and rest and things like that. But many times, if it's narrow enough, if it's this narrow, then they're going to have to do some sort of intervention. That includes, doing a laminectomy, just removing the lamina and the posterior elements here. Taking back some of the disc is another way to open up the canal. There's a kind of minimally invasive way of taking out this thickened ligamentum flavum as well. That's another possibility. There's not a whole lot you can do about the hypertrophy of the facet joints because it's bone and you can't really drill it away or anything like that. So this is multiple sclerosis, which you may have heard of. We most often see it in the brain in patients with multiple sclerosis. It's a demyelinating disease, and in the brain, I'll just mention briefly, you see these T2 bright areas. They're bright and flare, bright on T2 weighted imaging, just kind of scattered all around the white matter. You can see a similar finding in the cord where you'll just see T2 bright areas in the cord. And then after contrast administration in both the brain and the spine, you may see some contrast enhancement if it's an active plaque, if it's actively demyelinating. In the brain, you'll also be doing diffusion-weighted imaging for this. I think occasionally some people may do diffusion in the spine, but it's not super common. These patients, they'll usually come in with the known diagnosis of multiple sclerosis in the brain. Then they'll order to do a cervical spine and a thoracic spine to see if there's any disease in the cervical and thoracic spine. And these ones will always be, with contrast administration. If you ever see it, one was ordered without contrast and the indication is multiple sclerosis, you'll probably be checking with the radiologist or the ordering doc to make sure, that they don't want to add contrast to that. As far as what the patient's symptoms they can have, acute attacks where maybe acute demyelination is going on, or they can have, numbness or neurologic changes, weakness. It can be progressive. Sometimes it can be, just, intermittent and the attacks resolve. It's really variable in all different patients. So when they have an acute attack, it's unreasonable to do an MRI and see if there's anything going on. This is another spinal tumor, a spinal meningioma. Meningiomas are, pretty common benign tumors. They're quite a bit more common in the brain, but they're fairly common in the spine as well. They cause a little bit more trouble in the spinal canal because there's a lot less room for them to grow, whereas sometimes brain meningiomas can grow very slowly over time and not cause any symptoms. So they're going to have the same symptoms, once again, that we have with all space-occupying processes. If you have noticed the theme, anything that takes up room in the spinal canal is going to cause pain, numbness, weakness, that kind of thing. Just like with the ependymoma or any rounded thing that you see in the spinal canal, you're going to want to give contrast because that will help the radiologist, determine where the lesion is in relation to the cord. Is it inside the cord? Is it in the intradural space, extradural space? And it also help, the enhancement characteristics help you kind of narrow down what kind of tumor it is. And these ones, usually have to be resected, and the patients will have a good prognosis after that. Here's another image of a spinal meningioma. Occasionally, you can see a little bit of an enhancing dural tail that goes along with it. That's another good reason to add contrast, because you see this little tail gives you another clue that it could be a meningioma rather than something more concerning like a metastatic lesion.
How can you tell that apart from that meningioma?
Sometimes you can't. Sometimes you can't tell the difference between a meningioma and a ependymoma. That's true. Sometimes you have to just say it could be this one or that one. Either way, both of those lesions have to come out, so they'll get the diagnosis on pathology. And fortunately, you don't have to make 100% definitive determination at that time. A lot of the most important thing would be to tell location and what the effect on the cord is. Is there any edema in the cord from compression and things like that? Here's an example of metastatic disease to the spine. So unfortunately, cancer is quite common, and once it starts to spread throughout the body and in the bone, it can spread to the spine. So metastases to the spine usually come from spread through the blood rather than a direct extension of the tumor. So basically any malignant metastatic disease can involve the spine. They're mentioning that breast and lung carcinoma are the most common. Those are, of course, some of our most common cancers in general. You may be frequently evaluating patients who have a history of cancer, have new onset back pain, have new onset pain, weakness, numbness, that kind of thing, all those same symptoms. It'll be evaluating them for metastatic disease. And typically you'll want to give contrast with these as well. The tumor can be confined to the vertebral bodies themselves if it's just a bone metastasis. They can be solely within the canal or in the cord, or it can be a combination of both. If a tumor is in the vertebral bodies itself, it has a chance as it grows to, extend posteriorly into the epidural space and cause really significant cord compression. Can extend into the paraspinal muscles and that kind of thing. So the contrast kind of helps you determine the extent of the soft tissue part of the lesion. Obviously, we can see the bone part of the lesion pretty well without contrast, but the soft tissue is an important thing to characterize as well. If you were to see some metastatic disease on the spine, as you're scanning, one thing you'd want to probably call a radiologist about, get things moving on, is if you see something like this, where this is a big lesion of the vertebral body and it's expanding posteriorly, and it's really compressing the spinal canal, and it's really compressing the cord a lot there. And we're not seeing any definite signs of cord edema, but the sooner that you decompress the cord, as far as mass effect on it, the better the patient's going to do neurologically. So keep an eye out for the lesions to see if there's anything worth giving contrast for, if it hasn't already been ordered, and then also any signs of cord compromise. We want to take action on that before the patient leaves. Start talking to the doctor and come up with a plan. The patients may end up going straight to neurosurgery from your scanner. So this is another picture in axial of the metastatic disease. In this case, the tumor here, because metastatic disease doesn't always just involve the vertebral body, can involve the posterior elements of the spine. This lesion has really spread into the canal and is causing severe narrowing of the cord. So this is an emergency when you see it this advanced. So the other option that they mentioned here is radiation treatment. So many patients with spine metastases will get radiation treatment. Usually, if there's cord compromise, you wouldn't want for radiation wait for radiation to take effect. You'd have to just decompress it surgically. Of course, the prognosis is not great for metastatic cancer, but if you intervene soon enough, you can allow the patient a better quality of life towards the end, so the patient doesn't end up in a wheelchair or in bed for the last few months or years that they have. This is another really important condition to diagnose quickly. This is vertebral osteomyelitis, or discitis osteomyelitis. We often describe it as, because the osteomyelitis, as you know, is an infection of the bone, and discitis osteomyelitis is an infection which kind of begins in the disc and spreads into the inferior end plate of the vertebral body above and the superior end plate of the vertebral body below. So occasionally this can happen, from hematogenous dissemination. If the patient has bacteremia, it can just spread to the vertebral body. But the infection really sets up very nicely in the disc and then starts to destroy the end plates around it from there. So what you're looking for is some really, terrible, irregular-looking end plates surrounding both sides of the disc, not just on one side. And then on the T2 weighted image, which we don't have, you'll see that in the disc space you'll see a lot of fluid signal, and that's a signal that this isn't just average degenerative disc disease that's really bad. This is discitis osteomyelitis. And if it's gotten so bad that the patient has developed an epidural abscess, you may see an abscess that's encroaching into the epidural space and causing compromise of the canal. In this case, they gave contrast, which is really helpful to help you identify an epidural abscess, because sometimes they're not always this large and they're difficult to see. So if you ever see, something that looks so irregular and so, so heterogeneous, a lot of bone marrow edema in the vertebral body, which would be, low on T1 and bright on T2, you see that around a disc, you should think about giving contrast if you can. This is something that usually doesn't require surgery unless they have an epidural abscess that is large enough to cause compression of the cord or the nerve roots. So sometimes they'll have to do it to drain an epidural abscess. If it's mostly just confined to the disc, they can treat it with antibiotics, but it takes a really long time of antibiotics, with intravenous antibiotics, some time in the hospital. It may undergo relapse, and the patients can often have long-term consequences where, these vertebral bodies are never going to be normal again. That's not going to grow back and be a normal end plate. So you can even see consequences down the line. The most important thing for this is just to, keep an eye out for it. Make sure that you give contrast if you see it. If you see it in a patient that you saw in the outpatient setting, you might want to let them go until you get someone, to take a look at it, see if they want to send the patient over to the hospital, get treatment started as soon as possible. This is actually very painful. The patients will usually show up at the hospital with it to begin with. So here's a burst fracture. This is being shown in an axial CT, but sometimes you may be evaluating this with MRI. This is a kind of vertically oriented the fracture of the vertebral body, which you can imagine is that the body gets compressed very quickly, and the body and the posterior elements it's a ring, so it can just kind of burst out like in a concentric fashion. So this can happen with either usually a flexion injury. Sometimes a patient has a quick stop. This happened a lot more before we had shoulder seat belts, where they would get a burst fracture in the lower thoracic, upper lumbar spine area. These will be trauma patients. Of course, they'll be usually younger patients, because younger patients get into more trauma. The patient's going to have a lot of pain, obviously, with it. So the patients, these are trauma patients will usually be evaluated by CT first, but where MR is especially going to come in to play is to see when these bony elements start to herniate posteriorly and compromise the cord, you're going to need to check and see if the cord has been bruised or if there's any cord edema, anything that would be a surgical emergency. Otherwise, they can let these fractures heal, or they may just stabilize them by fusing the vertebral body above and below and give it a chance to heal without too much, flexion and movement of the bone pieces. But if your MRI shows that there's anything going on with the cord, then they may have to go in and decompress the posterior elements quickly so that you avoid damage to the cord. This is another kind of vertebral body fracture, the C1 fracture. This can occur in the posterior arch, or the lateral masses, these parts, or in the anterior arch, or it can be all three. Sometimes they just break it in all three places. These are usually these are known as a diving injury. Usually people dive into water that's too shallow and they bang the top of their head, and this is another thing where the axial loading causes it to kind of burst out. Now, fortunately, in this case, when the C1 vertebral body bursts out, it's not going to go posteriorly. None of the fragments are going to go posteriorly and into the spinal canal, unlike within a burst fracture of the other vertebral bodies. So even though it's not necessarily considered a stable fracture in all cases, the patients usually have a lot more room around their cord up at that point. And so chances are these can heal without surgery. Of course, they're going to have to be stabilized in a neck brace. So the reason you might be evaluating this on MRI would, of course, be the same reason as the burst fracture, just to make sure that there's no impact on the cord, no contusion of the cord, that kind of thing. Here's a compression fracture. This seems kind of similar to a burst fracture, but these can often happen with very minimal trauma or no trauma at all. They can happen, usually they're associated with osteoporosis in older patients. If you've ever seen an older patient with, all these vertebral bodies are wedged like this, and then you know that they've had many compression fractures. Sometimes they go unnoticed and undiagnosed at the time of the actual fracture. Sometimes, they're known at the time of the injury, and so you may be asked to do an MRI just to see if this was acute or if this was an old fracture, because on CT and on X-ray we rarely can tell if it's definitely acute. You won't always see really defined fracture lines like with our burst fracture and the C1 fracture. So what you'll see with MRI is that the bone, with an acute one you'll see bone marrow edema. With an older one you're not going to see any of that bone marrow edema, the T2 bright T1 hypointense signal that you see with all acute fractures. It's important, if a patient has significant retropulsion of the bony part, that's what we call it when a portion of the bone goes posteriorly. And this doesn't happen that often. But if it's happened, if we can see that obviously on X-ray or CT, we'll also ask for an MRI to see if there's any compromise of the cord, how it's affecting the nerve roots and that kind of thing. But many of them don't always necessarily need to be evaluated with MRI. But if you see one like this where it's really affecting the cord, you might want to let someone know, make sure that they're aware of it so that they can take care of it in case they need to do a decompression. The way that they can treat these, many times they may just leave them alone and control the patient's pain. Especially if there's no compromise of the canal, which is usually the case. Sometimes if the pain is really bad, they may go ahead and put bone cement into that vertebral body to reinforce it, because the bony fragments moving around, it causes more pain. So if you stabilize it, then then you may decrease the pain. They used to try to kind of pump the vertebral body up with a balloon and then fill it all in and really try to restore the height of the vertebral body, but that has kind of mixed success whether it actually helps the patient or not. Sometimes it just seems to help with pain control, to just stabilize everything. So this is a hematoma in the spinal cord. This is a hematoma just like you can have anywhere in the body. You can also have one in the spinal cord. This is going to be a traumatic injury when there's been a really significant force to the whole spine and specifically to the cord. So you're often going to see this with other injuries, other associated abnormalities. You can have obviously fractures, retropulsion like we saw in that last case, an acute herniated disc, that kind of thing. A lot of the time it's going to be due to motor vehicle accidents is what are most kind of trauma. It can also happen from diving accidents and those kinds of things. Once again, with any traumatic injury, younger people are more likely to be affected, and especially males. So the patient is this would be probably in the acute hospital setting. They'll know that the patient would have had, a really significant trauma, is having some neurologic deficits, and so, they may not be able to tell exactly what's going on with a CT or an MR because there may not even be any fractures, and so they'll, go on to see an MRI to see if there's any hematoma, any compromise of the cord, and also to look for any of the, any ligamentous injury, some edema between the ligaments that would give you a hint that there was really a significant force on the spine to cause the cord to become, damaged enough to actually bleed into the cord. So the signal intensity kind of varies over time, but you can kind of stick with that. Most blood is going to be a bit bright on T1 weighted imaging. If it's a little bit low, then it's going to be very, very acute, and then you're going to see on the T2 weighted images some surrounding edema. As that blood starts to clot more and the blood products degenerate over time, you'll get that lower T2 weighted signal around it. And occasionally, if they do any gradient echo images, you're going to always see a low signal intensity from the blood products on gradient echo images, but you don't often do that with the spine. So yeah, the prognosis is not very good when they actually have bleeding into the cord. There's not much you can do even surgically to take care of that. So this is an image of a fracture dislocation at C6-7. Subluxation is kind of like the anterolisthesis, spondylolisthesis, but it implies that it's happened under a more acute circumstance. So, like in this case, a traumatic condition. So the reason it would happen at the lower cervical spine, you can imagine if your head bent forward and then backwards, you could fracture the vertebra, disrupt the posterior ligaments, and cause a damage to the cord itself. So this one is showing the fracture of the vertebral body. There's a bit of a disc herniation from the trauma too. And this is a T2 weight image showing this T2 bright signal in the cord. Unlike with the hematoma where that was bright on T1 weighted imaging, this is just edema in the cord. This just means some fluid has built up in the cord. There's a good chance this could resolve. But if if there's enough of a narrowing of the canal there, they may want to open it up surgically in order to give that cord a chance to heal. Depending on how bad it is, this may heal, or sometimes the cord may always be a little bit thin there. They may get a little bit of myelomalacia when it heals, but eventually that T2 weighted signal will go away. It does say, the presence of hemorrhage is a poor prognosis. The presence of edema doesn't necessarily mean that the patient is going to always be paralyzed. It sometimes resolves over time, and with rehab and things like that, the patient can get function back. These patients will usually, with these cord injuries, are usually going to go to a place that's specialized for spine trauma to act really, really quickly anytime they need to, and then they're going to be really good with the follow-up care. And the patients will probably have, multiple MRI studies over the course of their, rehab and things like that, just to see how the cord is doing. This is an image of the spinal cord ischemia infarct. Just like an infarct in the brain or in the bowel or anywhere else in the body, it's just a disruption or absence of blood flow to the cord. Of course, it can be really devastating in the spinal cord because you're going to end up with neurologic symptoms as a result. Anything that can cause ischemia can result in ischemia of the cord. The cord has blood vessels going to it. Any of them can be blocked off by atherosclerotic disease or, little emboli or blood clots, or, you're at higher risk if you have something like sickle cell anemia where your blood cells are not completely normal. Diabetes where your small blood vessels are, pretty irregular and don't always give a good blood supply. So what you're going to see is that the patient is, of course, going to have loss of sensation, reduced sensation, and diminished motor function, especially in the lower extremities. and they'll order an MRI for this. You'll see that, there's no compromise of the central canal. There are no bulging discs, no spondylolisthesis, anything like that. You just see, all this edema in the cord, flare imaging showing a T2 bright signal in the cord. That just indicates that the cord is, inflamed. It's taking on fluid, and that happens whenever cells die from, not getting enough blood supply. It's the same kind of thing that you see on a flare image of the brain when a patient has an acute stroke. Fortunately, this is a little less common than a stroke in the brain, and they may be able to restore blood flow with certain blood thinners and things like that. So, if you ever do see that, you want to, let the radiologist know so that they can try to get treatment going quickly. It's just like with the brain. The sooner that you intervene, the better. Many times with good rehab and things like that, the patient will be able to restore function. There is just a couple of images of the some neck pathology here at the end. One of them is branchial cleft cyst. It's a congenital anomaly that patients may or may not know that they have until later on in life. Sometimes patients just notice that they have a swelling on the side of their neck or face. It can, go anywhere from about halfway up your cheek where the angle of your jaw is, down to down to your lower neck here. It just depends on what the origin is. And what you'll see is this, really very well circumscribed lesion that's along the anterior and medial aspect of the sternocleidomastoid muscle. That's right here, and posterior to the submandibular gland. So it's separate from both of those structures. And it'll be this is a CT image, but on T2 weighted images, it would be usually very bright in T2 in T2 signal, and hypointense on T1 weighted imaging, just indicating fluid content. Sometimes if there's a little bit of proteinaceous material, it may be a little bit intermediate on the T2 weighted imaging. Sometimes it can become infected, so in this case you may want to give contrast depending on whether the patient's having pain associated with it or if they just notice a swelling. So it may help you figure out if there's infection by giving contrast. You'll see contrast enhancement all the way around that. And they usually just surgically resect these, and the patients do fine. There's no consequences of it. So a glomus is another tumor of the neck that looks like it's in a kind of similar location, and it can sometimes be difficult for the radiologist, to figure out exactly what they're dealing with if they, just have limited imaging. But this one, fortunately, enhances really well in T1 weighted imaging, so it becomes very easy to differentiate from other things. And so this is a post-contrast image showing that it's really, really very bright on imaging. And these two arrows are pointing at the external and internal carotid artery. So if you think of the common carotid artery coming up to your brain, the internal carotid artery keeps going cranially and it's posterior, and the external goes a little bit anterior and starts supplying your face. So this tumor just sits right in the middle of those. It's called, that's why it's called also a carotid body tumor. And it's a type of a paraganglioma. There, you can see paragangliomas in multiple locations in the body. So this is the specific name of it when it happens in that location. This is also a benign tumor, but it usually has to be resected as well. So so if you saw any tumor in that location, or basically any tumor in the neck, you would definitely want to give contrast. And one other thing on these, they may have flow voids in them that usually see a little bit better on the T2 weighted images. It gives it a kind of salt and pepper look. Here's a parotid gland tumor. There's a few different kinds of tumors that can occur in the parotid gland. We usually don't identify exactly what they are before resecting them, so it's kind of similar to the ependymoma meningioma question. So what you'll see is just usually they're fairly well circumscribed lesions with enhancement. You may see one on the other side that may give you a clue as to what the etiology of it is. Sometimes you can have a lymph node within the gland that would have a kind of confusing appearance. So usually getting these in a few different planes will help you tell whether it's a lymph node or not. So Sometimes these are, just idiopathic. Sometimes they mention radiation as a possible treatment. Sometimes the patient will notice these as a swelling on the side of their face, or sometimes they may just be discovered incidentally during imaging that's done for another reason. So, so it might be helpful to give contrast if it was an undetected lesion and they weren't planning to give contrast for that one. They always just have to resect these. Sometimes we try to biopsy them ahead of time and get an idea of what it is, but many times they just surgically excise them and get the pathology from there, because even the benign ones will have a little bit of a low malignant potential, so you have to just take them out anyway. A lymph node, though, you wouldn't resect. So having the imaging in at least a couple different planes to look for that, fatty hilum, the normal lymph node shape of a kidney bean would be helpful. This is an abscess within the submandibular gland. Of course, you can get abscess many different locations in the neck. So this is just one example of one that you have. This is the submandibular gland. You can see the normal one over here. This is on CT, but you'll see similar findings on MRI. The one up here has this area of hypodensity, or decrease enhancement. In the case this is a contrast enhanced study. On a MRI image, this would show up like a fluid signal intensity, T2 bright area, and that's compatible with an abscess. On this one, this is showing a calcified stone that is developed within the gland. That's known as a sialolith. Sometimes the sialoliths can lead to obstruction of the gland, because normally your salivary glands are draining into your salivary ducts and into your mouth. So if it's obstructed, sometimes the material can get backed up and then occasionally get infected. Sometimes it can just cause enlargement and swelling of the gland as well. So that'll appear, rather than being a T2 hyperintense area within it. It'll just be overall kind of larger than the other side and a little bit more edematous than the other side. And you'll see a bunch of little folds within it. And the major thing that you're looking for in those ones is that it's just asymmetric from the other side. It's fortunate that a lot of things are symmetric in the body. So there's a little bit of variability in the size of people's submandibular glands and the signal intensity of people's glands. So sometimes you just have to look at the other side. But of course, if you saw something really well-defined collection, then you'd know it was an abscess. On MRI, it's a little bit harder to diagnose the sialoliths, to diagnose the stone as the cause. Of course, they're going to be low in T1 and T2 weighted signal, but if you saw these kind of abnormalities in MRI, you may even have the patient go on to a CT for further evaluation, which is funny because it's usually the other way around. Sometimes if there's an abscess, they may have to drain it surgically, or percutaneously put a needle in it and drain it. Or they may just give antibiotics. This is just a slide mentioning thoracic outlet syndrome. You may be doing brachial plexus MRI occasionally. There's a variety of different conditions that can affect the brachial plexus. This one mentions thoracic outlet syndrome because that can definitely affect the brachial plexus. And sometimes you may even be asked to evaluate the brachial plexus in different positions, because the patient may have symptoms in different positions, whether they have their arm up or down. But that's fairly advanced imaging. Most of the brachial plexus imaging is going to be in neutral positioning. So these are often diagnosed based on clinical findings, but they would just want to make sure there's no other pathology going on there, say with the brachial plexus. And sometimes if it's due to an extra rib, or something that they can resect surgically, they'll resect it. Otherwise, they may just have to do some physical therapy that helps to kind of align everything better so that it doesn't cause so much compression at the thoracic outlet. Okay, so now I'm going to go on to the musculoskeletal pathology. That was kind of an introduction into that. So musculoskeletal pathology, you're frequently going to be evaluating the larger joints like the shoulder and the knee. This is one entity that can occur in the shoulder. This is called a Hill-Sachs defect or a Hill-Sachs fracture. It's actually an impaction fracture of the posterior and a lateral aspect of the humeral head. This occurs with an anterior dislocation of the shoulder. The shoulder usually dislocates anteriorly, and where the humeral head bangs into the glenoid is where you can get this impaction fracture. And likewise, you can have a fracture of the glenoid called a Bankart lesion on the other side. So sometimes you'll see both of them, sometimes you'll see just one of them, and sometimes you won't see a fracture with the Bankart lesion, the one of the glenoid. You'll just see an injury to the labrum itself. So MRI is especially useful for showing that. Sometimes the Hill-Sachs defect and the Bankart fracture are visible on X-rays, but many times they may be subtle. So this one's showing a really large, obvious defect in the humeral head. Many times you won't realize that there is an impaction fracture until you do the MRI, and you see on the T2 weighted image, you're going to see this band of edema just in that area, and then you'll know that there's been, you can tell right away this patient's had a shoulder dislocation. They have a Hill-Sachs injury. They don't repair this kind of fracture, but but just to do some rest, and then eventually some rehab. If the patient continuously dislocates the shoulder, they may have to do surgery to kind of tighten things up and prevent the recurrent shoulder dislocations, because every time you're at risk of damaging the humeral head and especially of damaging the labrum of the glenoid that the humeral head sits in, and that's what's going to cause a lot of the pain and stiffness from multiple dislocations or even one very bad dislocation. You may be doing these studies as well on patients with a known shoulder dislocation in order to evaluate for the Bankart lesion, the labral tear that goes along with it. They may do an arthrogram just to give contrast, give you a better chance of seeing the labral tear that would go with it. And this is an example of a labral tear. These can happen, like I said, with the shoulder dislocation, or sometimes it can be a little bit degenerative in etiology. It can happen from a fall. It can happen a lot with, baseball players, pitchers specifically are at risk for this. And you can see that you've got this little black outline. This is the bone of the glenoid that the humeral head sits in, and the arrow is pointing to this little bright signal in there where either the fluid in the joint or the contrast that you've given for MR arthrography really highlights this little tiny defect in the labrum. And although it looks small, this can be really painful, and then long term it can lead to arthritis of the shoulder and stiffness, that kind of thing. So you'll definitely be evaluating patients for labral tears, especially athletes, I'd say. Sometimes they'll reattach the labrum, they'll do surgery on it, and sometimes they'll just do physical therapy to try to support the surrounding structures in the shoulder. This is another thing that you're going to be evaluating really frequently. So the rotator cuff are these, it's actually a combination of 4 tendons that come from the supraspinatus, infraspinatus, and the teres major and minor. Oh, they come from the muscles, and they surround the humeral head. And the tears, or evaluation of the rotator cuff, is usually referring to a tear of the tendons and not of the muscles itself. So this can happen with a variety of conditions. It can also be associated with sports. It can be a sports injury from repetitive throwing, like overhead throwing with baseball, or it can more frequently be due to some impingement on the rotator cuff by the bone around it. So let's say, for example, the supraspinatus, which goes over the top of the humeral head, let's say it's constantly being rubbed against the acromion. If the acromion has some spurring underneath it, and it's constantly being rubbed back and forth every time you raise your arm to the side, it can eventually kind of tear through the rotator cuff. And the tears may be a full thickness tear where it goes through and through. It may be a partial thickness tear where it only goes part way through, and it can be a longitudinal tear where it goes along the length of the tendon. So a lot of different ways that the tendon can tear, and that will depend on and how it looks on the MRI is going to depend on how they treat it. If it's fully torn and it's been retracted long enough that the muscle becomes atrophied, then there's no point in really doing any surgical treatment at that point. So MRI is going to be really important, not only to look at the tendon in that case, but to look for signs of edema in the muscle. Edema in the muscle means, acute atrophy is going on, and then eventually, edema being a bright T2 weighted signal, and then eventually when it becomes atrophic, it'll be fatty signal on T1 weighted imaging, and that'll tell you that it's a bit too late to repair the rotator cuff tear. You can always strengthen the surrounding muscles and try to support support the rotator cuff with the surrounding muscles, but you wouldn't repair in that case. Now, if it's a longitudinal tear, you can probably get away with just doing some rest and immobilization, eventual physical therapy. If it's a partial tear, or if it's in a very recent or acute full thickness tear, they may surgically repair it, and they'll sew those pieces back together. So not only will we be evaluating these patients when they first have the injury, or maybe long after they have the injury, to see if it's worth repairing, you'll also be evaluating them afterwards to see the integrity of the repair, if the patient has a return of those symptoms. What the patients feel when they have this, besides having pain, is that they have weakness, and they have, they have a lot of trouble lifting their arm out to the side. That kind of thing would be the most common thing. So when you're asking the patients their history, and they say, I have shoulder pain, you can ask them, any trouble raising your arm above your head to the side, and that kind of thing. The orthopedic surgeons are pretty good at diagnosing when there's a rotator cuff problem. They may not know exactly which tendons are involved, but they're pretty good at diagnosing it based on physical examination findings. But your history can always be helpful to the radiologist as well, because they don't get to do a physical exam on the patient. So you may see some fluid as well in the bursa, or you may be diagnosing this on a patient who's had an arthrogram, in which case the contrast just helps outline the tear of the tendon. So the tendon is supposed to normally come all the way across to here and attach over here, but this shows that it's disrupted. And on this one, this is the oblique sagittal image. You can see the other tendon back here, and there's this kind of bald spot here where the supraspinatus is supposed to be. So it just, it looks like kind of a bald head when you look at it on the sagittal images. Yeah, here's another. This is a good example because it shows you what the normal rotator cuff does. It just comes along, nice dark black signal intensity tendon, comes in and attaches on the humeral head. In this case, you don't see that normal, black tendon continuing on where it's supposed to attach here on the humeral head. You just see a fluid intensity there. Whether this is fluid from an arthrogram or from a joint effusion, it doesn't matter. You're dealing with the same thing, the complete rotator cuff tear. This is showing a biceps tendon tear, quite a bit less common than a rotator cuff tear. It takes usually quite a bit of force usually on a kind of degenerated tendon to cause this biceps tear. You know how you flex your bicep just like you're showing your muscle. If you exert this forced flexion on maybe a heavy weight or something like that, and the tendon is not in great shape, say with an older patient, it has a chance to rupture. When you see a rupture, the tendon, this is the muscle that's all curled up, and the tendon becomes all retracted and kind of buckled there. The tendons of the biceps normally comes down and inserts down here in the forearm. So this one's being curled up all the way here, and you see all this bright fluid signal from the edema surrounding it. Same thing on the axial images, just a lot of edema, and including a little bit of edema in the bone. Where it was supposed to attach. So these ones will also often be diagnosed ahead of time on physical examination, because you'll see that the patient's muscle is all balled up here. It looks kind of similar like it does on MRI. It looks like the patient has more muscle than you think they should have based on the rest of their, or on the other arm. But sometimes MRI is really helpful in telling you whether it's similar to the rotator cuff, whether it's a full thickness tear, partial thickness tear, does it need a surgical repair, is this something that will heal with immobilization. Certainly something that's retracted all the way up here is going to need to be brought back down and reattached. But if it's only partial thickness tear, then the patients may heal up with some conservative treatment. Likewise, you can have a similar kind of finding in the back when you tear your triceps tendon. Once again, a lot of force on probably partially degenerated tendon would be the most common cause. This doesn't happen that often, but once again, you may notice some balling up of the muscle on physical examination. You're going to see the same thing, that the tendon itself is kind of retracted and wavy, and then you have this blank space where there's no tendon before it's supposed to come down and insert on the elbow there. So this can be a partial tear or complete tear. MRI is going to be really helpful to tell whether this is something that has to be surgically repaired. Once again, very, very similar to the biceps tear, just on the other side. A ganglion cyst is something that you're going to be looking for on your wrist MRIs really frequently, although they can occur in other locations. It's really just a little fluid intensity, T2 bright, T1 hypointense thing that you see around the joints or the tendons of the wrist. The patient will usually come in with a lump on one on the side of their wrist or on the back of their wrist, and they can happen associated with the carpal tunnel, or associated with flexor or extensor tendons. They may or may not be painful. Sometimes they just notice it because they notice the bulging of it. You can see that you'll be having the patient put a vitamin E capsule. They missed the spot on this one a little bit, actually. It's good down here, but sometimes it's hard to tell, I guess. And it's a benign thing, but they do, usually surgically excise it, just because it can cause some compression and pain, depending on how large it is. So this is a tear of the triangular fibrocartilage. On the ulnar side of the wrist, you see this is the ulnar styloid, and you have this triangular fibrocartilage extends from the lunate and the triquetrum to the ulna, and many times this tear can occur because of a trauma that occurred, any kind of trauma that could either break the ulna or tear the TFCC, so something like a fall, on an outstretched hand, that typical thing. Or sometimes it can occur just as a degenerative process with, it can be seen with rheumatoid arthritis or, other like inflammatory arthropathies or depositions. And so you may be evaluating this with MRI, and what you'll see there is just similar with other things. You just see a fluid signal where you should normally see a nice black cartilaginous signal. This is an example of avascular necrosis of the hip. This is something that kind of frequently occurs in the hip joint, but it can occur in other locations as well. Avascular necrosis is just the way it sounds. It's a disruption to the blood supply within the bone, and in this case, in the femoral head. And so that can cause edema within the bone, pain, infusion, that kind of thing. It can happen from trauma, but they're more often from other things, such as steroid use. If the patient has to be on chronic steroids for, say rheumatoid arthritis or, other conditions, or it can be associated with sickle cell disease. It is actually kind of associated with alcohol use. If people drink a lot of alcohol, they can sometimes develop this. At the beginning, it's going to be really hard to diagnose on x-rays, and that's the time when it can be, corrected. So MRI is going to be really important for finding this in a patient who's at risk. So you may have a patient who comes in with hip pain, has a history of needing steroids for another medical condition, and you'll do a hip MRI and you'll see some, low T1 signal in the femoral head, bright T2 weighted signal, and you'll know that you're dealing with some avascular necrosis in this typical location. And what you'll notice is that the signal intensity will be the most abnormality will be in the femoral head and not quite as much on the acetabular side, although you can have some reactive changes on the other side. And at first you're going to see that the femoral head has still a normal contour, but eventually the femoral head may start to collapse and flatten, and the joint space may begin to narrow. And at that point, it becomes a little bit too late for surgery at that point. You may have to do a hip replacement for the patient. So if you catch it with MRI at this early stage, when it's too early for us to see on a plain film or CT, the surgeons may decompress. They increase the blood flow by just putting a screw in through here, and the patients may end up having, stopping the process at that point. Sometimes even with surgical intervention, it'll go on to lead to like collapse of the femoral head, and then eventually narrowing of the joint and degenerative joint disease. On this one, there's a little bit of a similar finding on the other side, but it's definitely more obvious on this side. So yeah, sometimes they'll just have to end up going right on to hip replacement depending on how bad it is. Here's another example. This one has undergone that cord decompression where they drill through to the femoral head or put a screw into the femoral head. And this one on the other side, I can see this beginning of a little subchondral area of signal abnormality there. This one, you can maybe see on plain film as a sclerotic area, but many times it'll be too subtle, and you'll have to diagnose this on MRI in order to intervene on this as early as possible. This is one that's gone on to have a complication of a stress fracture in the femoral neck, so that of course would have to be surgically repaired. In this case, it's a pretty significant stress fracture where you see a lot of edema going through and through the femoral neck and really extending into the proximal femur. A little bit of a joint effusion that goes along with it. This fluid signal intensity there. This is something that you'll be doing MRI of the knee for quite frequently, an anterior cruciate ligament tear or ACL tear. They're quite common. You may know someone who's had one or had one yourself. They happen in athletes a lot. It's usually kind of a twisting, a pivot shift injury where the tendon, which kind of takes an oblique angle, gets stressed and pulled off. It can either be torn in the middle, it can be pulled off the bone at either end, or it can be just partially torn through the middle, or it may just have some abnormal signal from a really major stretching. MRI is really important to evaluate the integrity of the ligament and also to look for other injuries. So, you can have tearing of the medial meniscus, you can have tearing of it's usually actually the lateral collateral ligament complex, and some bone bruising in the lateral aspect of the lateral tibial plateau. You can also see a bone bruise in the medial femoral condyle as a result. So you'll be doing a combination of figuring out whether the ligament is torn or not, and also seeing what the other consequences are, and see if there's any cartilage injury associated with it. So the orthopedic surgeons can often diagnose this on physical examination because the anterior cruciate ligament prevents your knee from being your lower leg from being pulled forward at the knee. So they'll be able to tell that it's just a little bit too lax when they pull on it, but they won't know the extent of the tear. They won't know what the other associated injuries are with it until they get an MRI, and so that's where it's important to do the MRI. And you may occasionally end up doing, some locations will do a dedicated ACL view where rather than just going in a straight sagittal plane, they'll line up the imaging, the sagittal imaging with the plane of the ACL so you can get a really good view of it and make sure, see if there's any fibers intact, that kind of thing. Typically, though, you may just end up doing straight sagittal and coronal imaging. It's fairly obvious when it occurs. You can see the ligament should really, be going straight down, nice black line. You can see it's disrupted here in that portion. Here you just see basically no tendon at all where it's supposed to be attaching. So in this case, it was pulled right from its femoral attachment. In this case, it's torn kind of in the middle portion of the tendon. And here's an example of the normal one. That makes things a little bit easier to understand. We see the normal one, nice black line going, back to front. Same thing here, a little bit better visualized here. So the PCL, that's a posterior cruciate ligament That's another injury that you'll see a little bit less commonly than the intercruciate ligament tear. Once again, it can be associated with a pivot shift injury, but because there's a little bit more laxity in the tendon, you can see this normal one compared to the normal ACL one. It has a little bit more give in it, so it's a little bit less prone to injury than the ACL. But you're definitely at risk for it if you have a complete knee dislocation, which can happen. Or the other possibilities, if the knee is flexed and someone comes from in front and forces a hyperextension, it may cause tearing of the ligament. So once again, they're going to have pain, and the orthopedic surgeons will diagnose this on physical exam in the opposite way. They'll be able to push the lower leg back further when this ligament is torn, but you'll have to do an MRI in order to tell them whether it's completely torn and what any other associated injuries are. This one has a little bit less associated injuries like meniscal tears and things like that if it's an isolated PCL tear, but if it's a patient who's had a knee dislocation and that's the etiology, there are going to be lots of things that you need to evaluate as far as the bone, the cartilage, muscle bruises, collateral ligaments, and things like that. So here's an example of a quadriceps tendon tear. The quadriceps tendon, comes down and inserts on the top of your patella. And it's kind of similar to I like to think of this kind of like the biceps tear, where if it's, a forced contraction, especially on a little bit of a degenerative tendon, it may cause the tendon to just tear. I think you'd see it a little bit more often in older patients than in a younger patient, unless they were doing some, really intense physical activity. So here's an example of the normal quadriceps tendon. By now you realize that all the tendons, ligaments, usually black signal intensity, very dark signal intensity when they're normal. And when you start to see that it's discontinuous, or you see abnormal bright signal in it, then that makes you worry about a tear. This one you might know on physical examination, because the patient won't be able to kick their lower leg out. If they're sitting down, they won't be able to straighten their leg out in front of them. So the orthopedic surgeons will know that there's something up with that. They may even notice some bulging of the muscle depending on how much it retracts. Usually it doesn't retract quite as much as a biceps or triceps tendon tear, but they'll need to know, how extensive it is, how far up the tendon has been retracted, in order to know whether they need to do a surgical repair, if this is, something that's a partial tear that may heal with immobilization. So I guess if you were doing a nice knee MRI and you saw that there's a quadriceps tendon tear and you had a nice small field of view in order to evaluate the structures of the knee, but you couldn't see the rest of the quadriceps tendon, you might want to open up or shift a little bit higher in order to include where the rest of the tendon is if you don't see it on your study. So that's something to look out for. So Baker's cyst or a popliteal cyst, we see these incidentally a lot on MRI and even on ultrasound studies now that we're doing a lot of DVT studies. It's it's a fluid attenuation, fluid intensity structure that you see posterior to the knee, and it's actually technically in this semimembranous semitendinosus bursa, so it's right between those two muscles. You'll see just a little, elongated oval fluid intensity area. Sometimes these can be associated with meniscal injuries or, cartilage damage or just degenerative joint disease, basically any kind of injury to the knee, because many times they result from some of the fluid from the knee, from a knee effusion tracking into this bursa there, and then just kind of getting stuck there. So many times patients won't know that they have them. Sometimes they'll notice they'll feel swelling on the back of their leg and have it checked out, but sometimes they can be painful. And if it's symptomatic, they might resect them. Sometimes it's difficult to completely get rid of them. If the patient has degenerative changes in the knee and they're continuously producing more joint fluid that can communicate to the cyst. So it just depends on what else is going on with the knee, how they'll treat them. So here's an example of a bone bruise or bone contusion. It's actually, like, I guess you could think of it as kind of a really mini fracture that you never see on X-ray, or not really need to do surgery for. But they can occur from impaction force, kind of similar to the Hill-Sachs fracture that we saw in the humeral head. So you can see these in the tibial plateau. Sometimes tibial plateau fractures or contusions will be very difficult to diagnose on X-ray, and the patient will have really severe pain you won't know until you do an MRI. Here's an example where it's in the femoral condyle, in the medial femoral condyle. You see this increased signal intensity, and it's like the surface of the condyle is intact, but you see this edema underneath it. Another way that this can happen is just with insufficiency. Like if a patient has osteoporosis, sometimes it can happen spontaneously. They used to call that spontaneous osteonecrosis, but now we know it's due to bone insufficiency rather than actual, necrosis as in the avascular necrosis. So we've changed the name to it. So you'll definitely be seeing these sometimes for evaluation of knee pain, sometimes in combination with other injuries, but sometimes on their own. And so occasionally someone will come with this suspected abnormality on the X-ray. There's some subtle changes that you can look for, but once you see it on MRI is when you can make a really definitive diagnosis. You also want to be looking for, other associated injuries. If you see a bone bruise here, you'll be looking for a bone bruise on the other side, looking for any injury of the meniscus that's adjacent to it. That's the meniscus there, this little triangle that comes out, and any injury to the overlying cartilage, which is, supposed to be nice and black overlying. Speaking of the meniscus, here's an example of a meniscal tear. These are pretty frequent and common, and you'll definitely be doing a lot of knee MRIs to diagnose these. The meniscus you can think of as kind of a C-shaped cushion that goes between the tibia and the femur where they contact at the knee joint. You can have a traumatic tear of the meniscus, either from sports or from car accident. Sometimes patients will hit their knee on the dashboard, get a meniscal tear, and sometimes it just happens with degeneration over time, that the meniscus just kind of wears down, and one day your knee pops or something feels funny, and then all of a sudden it swells up and something's happened. So they can be associated with other injuries depending on what the mechanism of injury was, and sometimes they'll know that or be suspicious of it based on physical examination findings, because, say, in the example of medial meniscal tear, the patient will be quite tender along the medial side of their knee, so that's something you can ask the patient. If you have knee pain, where is the pain? They'll say, oh, it's really bad along, right here, and you can indicate that to the radiologist, because sometimes these can be a little bit subtle to diagnose on MRI. This is a really nice example where you have a really bright line going right through and through the meniscus. What we look for on them is to see whether the tear actually hits either the tibial or the femoral surface of the meniscus. That's when it becomes a true definition of a tear. If you just see some abnormal signal in there, it's not quite as black as the anterior horn here, then it may just be some degeneration. Not saying that can't cause patient pain, but it's it's whether it's a true tear or not kind of determines what the course will be from there. For true tear, they may or may not do surgery. It depends on what the symptoms are, how large the tear is, whether there's any displacement of the fragments. So, and these are really tiny structures. So sometimes it can be difficult to figure out exactly what needs to be done, whether it's something that they can and would do surgery on, or whether it's something that they'll just do strengthening for the surrounding structures. So making sure if you're looking for a meniscal tear, just making sure that you get really good sharp images. Definitely no motion on these ones. Repeating ones if there has been motion, that'll help them. The radiologist really figure out whether there's something that needs to be repaired or not. Long term, these can lead to, whether they are repaired or not, they can lead to knee arthritis. So this is just showing a fracture of the medial femoral condyle, and this is something that we may not be able to see. Unlike many fractures, we may not be able to see on X-ray. They can be quite subtle because there's not really a separated fragment that comes apart that you can see an edge, a line that we would see on X-ray. So they can be really subtle, and sometimes you'll just know the patient has a lot more pain than you're expecting for someone who doesn't have a fracture. Sometimes on an X-ray, you'll see the patient have a large joint effusion, a reactive joint effusion, that kind of thing, and you'll start to think maybe we should do an MRI of this. And so this is it's kind of similar to the impaction fracture, where you just see this low T1 weighted signal intensity line, T2 bright signal intensity line. This is actually where the fracture has occurred, and you may see a little bit of reactive fluid. You may see fracture in the medial tibial plateau. So MRI is really important for diagnosing these, just because they're so difficult to see. And unfortunately, even on CT, you may not see these, just because, especially in an older patient who has osteopenia, these can be very subtle. But once you see on MRI this really bright signal, then you're dealing with a fracture. And this can kind of go for any fractures in other locations as well that can be really subtle on CT or X-ray, especially in osteopenic patients. MRI is going to be your go-to for an occult hip fracture, an occult sacral insufficiency fracture that comes from osteoporosis. So MRI is really useful for these. It should be a fairly quick imaging test, and definitely worth the while to know what's going on with the patient. So this is an example of a bone tumor called osteosarcoma. It's a malignant tumor. It's a primary bone tumor. It's something that originates in the bone. There may be a little bit of predisposing condition if patients had radiation treatment in the area, but many times it's idiopathic. The patients never had radiation treatment. Unfortunately, they often happen in younger patients in the kind of their later teens, early 20s, and it's more often happens in males than females. And the patients are going to usually come in complaining of pain, and they may have a lump, a visible lump, or something that you only feel on palpation. And what they're feeling there is a combination of the tumor that's inside the bone, that's originated in the bone, and also the soft tissue extent of the tumor that extends outside the bone. So this is an example of the lesion that you can see encroaching within the bone, but then you can also see this area that is going outside the normal black cortex of the bone. So that's a characteristic of this lesion. It's not confined to the bone, where it's some more benign lesions will be confined inside the bone. Even if they expand them, they don't have a soft tissue part that goes outside the bone. So this is one that some orthopedic surgeons, in order to evaluate things, they may want to give contrast for this kind of bone tumor. We don't use a lot of contrast in musculoskeletal imaging. Sometimes it's sufficient. You can see even without contrast that the lesion is invading outside the bone. So they're definitely going to have to surgically resect this. Sometimes, depending on the extent of the lesion, sometimes they can get away with, in this case, doing kind of modified knee prosthesis, kind of like a joint replacement. Sometimes it just ends up being above the knee amputation, or wherever it needs to be, in order to completely get rid of as much tumor as possible. And then they'll always have to have chemotherapy, because these unfortunately have a very high chance of metastasizing, and it's hematogenous spread, so it can kind of go anywhere. But they frequently metastatic disease from osteosarcoma sets up in the lungs. So you'll see that the patients, once they have an MRI with you, they'll often be going on to CT to get a chest X-ray. These ones you may be able to see on plain film, because they're quite aggressive. They create some pretty dramatic changes in the bone, some really characteristic findings on X-ray. But MRI is going to be really important for evaluating the extent in the soft tissues, what muscles are affected, what does the surgeon have to work with in order to make this patient be able to walk after they get their treatment. And contrast that to this one, which it's only confined to the bone, and in this case, it's very bright in signal intensity. This is a unicameral or simple bone cyst. These are just a fluid-filled cyst in the bone. Sometimes it can just be one single cyst. Sometimes it can have some septations in it. There's another kind of bone cyst that will have many septations with it containing fluid in it. That's called an aneurysmal bone cyst, but they're similar entities. Not really sure what causes this one, or the aneurysmal bone cyst. And they may be asymptomatic. They may cause the patient pain if they end up getting a fracture from the thin bone that's out along this side, and sometimes you'll even see a little bone fragment has fallen into the cyst. You can see these on X-ray definitely, and so any patient who has an MRI of this, you may want to have them check an X-ray as well, especially for finding those little bone fragments, because they could be subtle on MRI. And these ones, sometimes, if they're big enough like this one is at risk for fracture, even if the patient doesn't have pain or doesn't have a fracture at this time. They'll put some bone graft, pack it in with some bone so that it grows in and fills in. The cyst becomes more like a normal bone, able to support the weight and everything like that. But it's a benign lesion, no risks after you take care of the risk of break. So this is the Achilles tendon. I'm sure everyone knows all about the Achilles tendon, and the Achilles tendon tear that we call the weekend warrior injury, because patients that are maybe usually not that physically active, like your dad goes out and he thinks he's 20 and he wants to play football or soccer or something, and he's showing off and he ends up tearing his Achilles. So this is something that you can often tell on physical examination, that there's something wrong with the Achilles tendon, because they'll be quite tender over that location. And sometimes if it's completely torn, just like with the tears of the biceps and the quadriceps, you can have a balling up of the muscle that'll kind of clue you in that you're dealing with an Achilles tendon tear. Sometimes it won't be that obvious, because it can be a partial tear, or it can be degeneration of the Achilles tendon. So MRI is going to be really useful for evaluating, obviously, like with most things, the extent of the tear and whether it's something that's going to need surgery or just immobilization in a walking boot or cast. If it's a complete tear, they're going to have to bring it down, pull it down. So just like with the quadriceps tendon tear that I mentioned, you just want to make sure that you include the imaging with your imaging. If it goes up high enough, that you include the distal part of the tendon, so they know what the gap is between the tendons. So just keep an eye out for that if you're imaging an Achilles tendon. So this just shows some abnormal signal in the tendon. This is one that's not a full thickness tear. If it's a full thickness tear, it'd be similar to the ACL tear, or any of those where you see complete disruption and maybe even some retraction. This is just a more chronic process. Here's an example of one where it's a complete tear, where the black tendon has been truncated and it's a little bit balled up. The tendon is a little bit thickened there. So you just want to make sure that you hadn't ended your field of view here, so that we can see how far away it is, for the surgeon to repair and pull it down. Usually these patients do fairly well, but it is quite a long rehab for that, whether it's a partial tear or complete tear. Here's the one reason you'll be doing imaging of the foot is to look for this Morton's neuroma, or intermetatarsal neuroma. It's just a focal thickening of the nerve tissue that you usually see between the third and fourth metatarsal heads. This is something that you may notice on physical examination, again, because the patient will have pretty localized tenderness, and so you may be, maybe ahead of time will know that that's what they're looking for. So you want to make sure that you include the metatarsal heads and the toes, the bases of the toes pretty well. So these develop just from irritation of the nerve, and they're kind of associated with having the metatarsal squished together in a tight shoe, or a shoe with a pointed toe that forces your toes to be too close together. So what you see is just a low T1 signal area, high T2 signal area. Sometimes it'll be even really fluid signal, and that's basically all you need. Sometimes you'll even see it as a little barbell squeezing between the two toes, the two metatarsal heads there. So osteomyelitis is an infection of the bone that you'll be doing probably really frequently, especially in the hospital setting, to evaluate for infection. Patients that are at risk for osteomyelitis are patients with poor blood flow to the feet, like diabetic patients. Especially you'll be seeing this in the toes a lot, where you'll see a lot of a defect in the skin there, where they've gotten a skin ulceration because the skin doesn't heal well, and that gives the bacteria a route to get in through the ulcer and through the soft tissues and all the way to the bone. Once it sets up in the bone, it's going to cause all this bone marrow edema, a lot of pain in it. So it'll be, right on T2 weighted images, dark on T1, just like, a lot of our bone pathology. And then you'll do an MR image. It's a lot more sensitive than finding these changes on X-ray or even CT as well, because the bone marrow edema, it just makes it really obvious. With CT and plain films, you may have to wait for the bone to actually be destroyed rather than just inflamed in order to diagnose this, and at that point, it's a bit too late. So many of these patients, especially if it goes on to that point, with something like a toe, is going to have an amputation of the toe. Surgery may just be useful if it's not a toe. If it's some smaller bone, they may just debride the bone, try to control the infection. Surgery may not be necessary in all cases. Sometimes just a very long course of antibiotics can treat it, but they may end up needing to do surgery just to get an accurate diagnosis of what the organism is so that they can treat it really well. So you'll definitely be doing a lot of studies for this. For osteomyelitis, you may sometimes be giving contrast. It helps you, evaluate the extent of the infection and evaluate for any abscesses around. But certainly you can diagnose this. You can see the edema pretty well even without contrast. All right, that's it then. Any questions? No? Okay.